Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, Dr. Jennifer Cocohoba, Professor and Vice Chair of Faculty Development at the University of California, San Francisco School of Pharmacy, and Dr. Jason Schafer, Professor and Vice Chair at Thomas Jefferson University College of Pharmacy, have a conversation about key takeaways for pharmacists from the 2021 International AIDS Society Conference. For more information about Drs. Cocohoba and Schafer, and for a link to additional online education on this topic and more, please visit the link in the show notes. With that, Dr. Cocohoba, take it away.
It's great to be here with you today, Dr. Schafer. One of the things I noticed from the IAS conference this year was we got a little bit more information about two-drug regimens. For example, I think there was a bit of data that came out around using lamivudine with dolutegravir.
Yeah, absolutely. There was definitely a number of analyses looking at two-drug regimens, and you're right on that there was a lot of information on dolutegravir and lamivudine as a combination. One of the studies that we know a lot about already is the TANGO study. This time around, it's the 144-week assessment of data. That's 3 years worth of data. And so just as a reminder to everyone, probably pretty familiar with this study, but just a reminder that this was a randomized open-label study looking at patients who were already virally suppressed for at least 6 months on a TAF-containing regimen and switched over to either dolutegravir and lamivudine or to continue on their TAF-containing regimen. And these individuals were followed along for a long period of time. We had analyses at 48 weeks and 96 weeks at previous conferences that demonstrated non-inferiority between these two treatment arms, maintaining virologic suppression at high rates. And now we have this 144-week analysis. It included, interestingly, both virologic and metabolic outcomes.
Right.
Metabolic outcomes being, the hot topic these days. So important to include in this analysis. First, virologically, we're still looking at non-inferiority in terms of maintaining viral suppression. And I think one of the most impressive outcomes from this study all the way through up until now is 0 patients with demonstrated virologic failure in the dolutegravir lamivudine arm, only 3 in the TAF-containing arm. No emergent resistance in either arm. So very durable in terms of efficacy, maintaining that viral suppression, 2 drugs versus 3 drugs. Very impressive in that regard, I think. And then from a metabolic perspective, we did see some weight changes in individuals over these 3 years, but not really different between the two treatment arms. 2.2 kilograms versus 1.7 kilograms might have been just normal weight gain that you might anticipate over these years in individuals. The lipid changes kind of favored the dolutegravir 3TC arm, but debatable as to whether they were clinically kind of meaningful differences there. And then the other novel piece in this study was looking at insulin resistance as an outcome.
Right.
They looked at a calculation called the HOMA-IR, insulin resistance assessment. Interestingly, at baseline in this study, lots of people already had insulin resistance, somewhere around 70%. That went up to 80% over that 3-year period. So whether or not that's drug-related or just a change over those 3 years for individuals, kind of hard to tell.
It really is. I think there's so much we're still trying to understand about the impact of HIV on these metabolic changes and all these new regimens. So it's tough.
Absolutely. I think, a lot of conflicting evidence out there in terms of weight gain and risk factors for weight gain. And there's still a lot to learn for sure. And so just another piece about the TANGO study, interestingly, they went back and looked at their 96-week data again, and they did this kind of interesting analysis of patients who achieved viral suppression. Were they achieving viral suppression but still having blips here and there, or were they having, these less than 40 viral loads but still detectable less than 40? They refer to it as target detected or target not detected. So if just as a recap, the viral assay that they were able to use measures viral loads anywhere from 40 to 10 million copies. If you're below 40, that assay can tell you, well, are you below 40 but detectable still under that range, which would be a target detected, or are you virally suppressed under 40 with no target detection? So I think, the question might have been, is a 2-drug regimen as good as a 3-drug regimen at getting that complete viral suppression with no target detection? And it turns out it seems to be. And numerically, it was a little bit better, actually, than the 3-drug regimen. So similar proportions of participants had that target not detected, somewhere around 70% or so. And they did this analysis previously at 48 weeks. So it was good to see that lasted through 96 weeks as well.
I think it's really interesting, this analysis, and we're starting to see these target not detected types of analyses. It's the how low can you go for viral suppression, right?
Yeah.
I think it's always a question to me whether or not that is a true marker of prediction for future failure. If you were somewhere between 0 and 40 copies, I know in our institution we're now at 20. We're down to measuring below 20 copies, and still frustrating sometimes from our patient standpoint when they see detected, when they look up their own labs, and then I get to explain what that means. So from a practice standpoint, what's your take on that?
Well, yeah, I definitely agree that it's a bit of a double-edged sword in a way, that we have such sensitive tests that can detect such low levels of virus. I remember when I first started out, the level of detection was much higher than it is now. And so people with viral loads of 200 or 300 would be undetectable on those older assays. Now we can go down to 20. And someone with 25 copies or 30 copies might think that they're not doing a good job, not achieving that undetectable viral load. And that's unfortunate. And it does lead to conversations about this. And some patients are actually quite stressed over being detectable. And of course, that is sometimes more analyze a little more with more scrutiny because of U equals U, and people are concerned, if I'm detectable, does that mean I'm going to transmit? But as a reminder to everyone out there, those U equals U studies, and in the guidelines now, tell us viral loads less than 200 really was what was appropriate in those U equals U studies. So I'm sure you have conversations like that with your patients. I do with mine. But it is important to be able to explain it to patients and kind of calm those nerves.
Totally. I completely agree with that. I still find these analyses really interesting. And I think, perhaps someday in the future we'll have a better understanding of what it really means, to have a target not detected and how that impacts future therapy. And so for now, I think it's good to kind of observe those, and, maybe someday we'll have a better sense of what 25 copies means in relation to 20 or 50 instead of 40, depending on your assay. But not only does it take 2 to tango, apparently it takes 2 to salsa as well, right?
Yeah, apparently. And I don't know if I can salsa, but I've never tried. But this study, nonetheless, was the salsa study, and it too looked at 2 drugs, dolutegravir and lamivudine. It was another randomized open-label study looking at non-inferiority. This time around, though, a little bit different from the TANGO study for a couple of reasons, really. And the first was the inclusion criteria. You had to be on a stable regimen and undetectable on that regimen, but it didn't have to be a TAF-containing regimen. It could be any regimen out there, 3 to 4 drug regimen. And It turns out a lot of people were on TDF, actually, the other tenofovir at the start of this study, almost half of individuals. The other noteworthy thing about the patients in this study, 40% female, much higher than what was enrolled in the TANGO study, where it was more like 90% male in that study. 60% white individuals in the SALSA study, whereas 80% in the TANGO study. 40% on integrase inhibitors this time around versus 80% in the TANGO study. So just to get a sense that this is a similarly designed study, but different in terms of some of the patients involved. So trying to kind of broaden that scope from what TANGO did, which I think is a good thing for sure. They too looked at virologic suppression, and we're looking at this at 48 weeks, showing high levels of viral suppression in both arms. Again, just like TANGO, we're seeing no confirmed virologic failures in either group, zero resistance. And maybe that's something to talk about now in terms of just what that means to you, maybe Jen, in your practice. To me, it speaks of durability.
Mm-hmm. Absolutely. I mean, it's something we're always so worried about is that and maybe this is just from, having grown up in an HIV practice where, 3 drugs, 4 drugs was the norm. And, I think not only practitioners, but sometimes patients who've been around through the HIV epidemic for a while are like, oh, wow, I can be on a 2-drug regimen. There's always, I think, these trepidations about fragility of these regimens. But the data that you're sharing around durability, we're not seeing, virologic failures. We're not seeing resistance emerging. And I know as practitioners, we're always trying to carefully sequence therapy so we don't ruin a patient's chance of having a future viable regimen. But these data, from both TANGO and SALSA are reassuring that you can be on a 2-drug regimen and it can last for quite some time.
Absolutely. The data, to me, very compelling, and do show a good amount of durability, no different, really, than being on a 3-drug regimen. And so I think as providers, we really have to start asking ourselves, does everyone need a 3-drug regimen? And, is less drug actually doing more benefit for the patient? Do we need 3 drugs for everyone? And I don't think the answer to that question is yes anymore. This data is strong enough over a long enough period of time that, in the right patient, and there are some things, to think about when you use at least this 2-drug regimen. You got to think about hepatitis B infection, right? You got to think about patients that don't have really any NRTI resistance, particularly the M184, right? You don't necessarily want to start someone on dolutegravir lamivudine if they have that resistance. And, in the SALSA study and TANGO, those people weren't supposed to be included in those studies. But for the right patient, maybe you just need the right 2 drugs. And these 2 drugs seem to be the right combination.
I agree. I mean, I think the other population we worry about is persons who have extremely high baseline viral loads. I think that would probably give me a little bit of pause as I considered a 2-drug regimen. But in this era of polypharmacy and really trying to minimize adverse effects, maybe less is more, as long as it's durable. Yep. I think that's the part we worry about, and that we want to be secure for our patients.
Mm-hmm. Agree completely. And the other thing that kind of came out of the IAS meeting, not just 2-drug regimens, but long-acting regimens as well. I wonder if you had a chance to take a look at some of those long-acting studies.
I sure did. I mean, I think as most people recognize, long-acting cabotegravir with rilpivirine was approved earlier this year. And so we do have that available on the market. And at the IAS study, there was an update of the FLAIR study, which was one of the studies on which approval was based. So FLAIR was a study of long-acting cabotegravir with rilpivirine in treatment-naive persons. So the basic outline of the study was these were persons who'd never been on antiretrovirals before. They started off on a regimen of abacavir, lamivudine, and dolutegravir. Then, as they split into treatment groups, some of them were then placed on the oral lead-in for cabotegravir and rilpivirine for the appropriate amount of time, 30 days, before switching over to long-acting injectable monthly therapy, while the other arm then continued on their oral abacavir, lamivudine, dolutegravir regimen. So we're up to, just like the length of the TANGO study, we're now at 124 weeks of FLAIR data. And this is essentially rolled over into the extension phase. This is the FLAIR extended part of the study. I think similarly impressive with the FLAIR study is that persons in the treatment arm continue to do well. And over the 124 weeks, there have only been 5 confirmed virologic failures since week 1 of the study start. And this study defined confirmed virologic failures as you had to have consecutive viral loads that were greater than 200 to be a confirmed virologic failure. So 5 is pretty impressive for the 283 patients that were enrolled in that particular arm. By intent to treat analyses, this means that, including study discontinuations of all kinds, not just for confirmed virologic failures, we're up around 80.2% of persons maintaining suppression all the way out through week 124. So we're seeing durability on these long-acting therapies and very few study discontinuations. One of the things I think people were worried about were injection site reactions. Right? These are big injections.
Yep.
But so far, it's only been 7 persons who've discontinued due to injection site reactions out of the original treatment cohort.
Yeah, it was definitely something that I was anticipating. We've kind of have dealt with injections for HIV medicines in the past, although not so successfully. So this was new and different, and I think most people kind of anticipated that people would enroll and maybe stop because of tolerability concerns, and that just hasn't been the case. And yes, there were some injection site reactions that are reported mostly early on in the study. And maybe that was due to the loading dose there at the beginning, but they seem to have gone down throughout the study, and tolerability overall seemed to be high. And you're right. I mean, the virologic efficacy seems to be substantial, not just over a short period of time, but now over a much longer period of time. So count me impressed with the cabotegravir rilpivirine injection.
I would agree. It's something we're looking forward to beginning in our practice as well. And there was another study that was presented at the IAS conference around just that practical aspect, getting started with long-acting cabotegravir rilpivirine in your clinic. This was the customized study, which was a phase 3B hybrid 3 implementation effectiveness study, which in summary by study design used both qualitative and quantitative measures to really understand all types of aspects of implementing this new therapy in a clinic. They looked at providers, healthcare providers, and these included physicians, injectors, administrators. There were 8 clinics. They surveyed them and did interviews at various time points. There were also patients that were included in the study. Appropriately, they wanted to get their perspectives on the implementation of these new therapies in their clinics. I think what was most impressive about this study is it actually took place during COVID. I'm sure that was not their intent, but it started in July 2019 and continued through October 2020. So they get my hands down. I'm very impressed they were able to continue with the study during COVID.
Yep, absolutely.
And I think there's a number of things that I thought were really useful that came out of the customized study. A couple of things that were reassuring to me were that overall, on a numerical scale, as they tried to measure acceptability, it increased from baseline to the month 12 with basically all different types of clinics, most stating by the end this was totally an acceptable intervention to implement into their practice sites. Another thing that was really reassuring is that for most institutions, that was 78% of the institutions that were surveyed, it took about 1 to 3 months to get into the optimal swing of implementation for this intervention. With a smaller proportion, about 17%, it took them 4 to 6 months. And for a very, very small proportion, 5%, it took them longer, or they were still in process of trying to get it up and running. Similarly, I guess to be expected, maybe not a huge surprise, but the ease of administration on a scale of 1 to 100 started around in the high 60s, so kind of 70% ease of administration. But by the end, it was increasing steadily up to the 90s in terms of their rating of ease of administration. Other things that I think we worry about as well is, are patients going to be able to stick to that 7 days plus or minus that you have to give the injection on time? And for most of their visits, about 94% of their visits, they were able to stay within the appropriate time frame to give an injection on time. Other little pieces I found really interesting and helpful, that time of visit. It took that first visit when they first started, month 1, the average duration of visit was 57 minutes. So an hour to administer the injection, get everything going. But that did decrease. By the time of the end of the study, around 11 months, the average visit time was 34 minutes. That's much more doable in our practice. That's the last piece I took away from the study, which again, maybe isn't that surprising, but is worth noting, is that the perceived barriers from the physician side were different than the perceived barriers from the patient side. So I think that's a very humbling reminder as healthcare providers that things we think are going to stand in the way are probably not actually problems from the patient's perspective.
Yeah, that was definitely one of the most striking results, with the percentages being so different on those scales, with physicians or healthcare providers thinking that there's going to be something in the way, that patients aren't going to come to their appointments on time, things like that, but the patients just don't see it that way. And the data kind of speak well to that most patients were quite adherent within that window period that you mentioned, even during the pandemic at its height. And, I thought it was just extremely encouraging to see the results the way that they kind of play out. This is as close to as kind of a real world implementation that we have in terms of these injectable medicines at this point. People I think criticize the Atlas and FLAIR studies, and rightfully so, to some degree, that it's not necessarily a real world setting, and the patients are so motivated, and there may be some selection bias there about who's getting enrolled into those studies. But this is as close to as real world as we have. And with many different clinics, many different types of providers involved, and patients, getting all those perceptions collected was very strong in this study. And it's encouraging that people did go through the growing pains. Those first 3 months seemed to be a little bit of a struggle, but once they kind of figured things out, things seemed to smooth out a lot. And, the patient perceptions improved, as did the providers. So that gives me encouragement. We're kind of stumbling out of the gate in terms of implementing these injections. We're trying our best, but this data is helpful to me.
I would agree. We're in the same boat as you. I think we're not in that 1 to 3 months time bucket. I think we're in the other bucket of taking a little longer to implement than we'd like. That being said, they don't talk about who they describe the population of persons included in the customized study as physicians, injectors, and administrators. And I saw it described in another study capsule summary as nurses, who I'm assuming they probably thought were injectors as well. As a pharmacist, being at the front and center of trying to get this medicine up and running, what are your thoughts on sort of the pharmacist role in helping the institutions get get systems in place. So,
yeah, it was a little disappointing to not see pharmacists involved in this study whatsoever, because I think pharmacists are heavily involved in the process of trying to get these medicines to patients ultimately, and whatever process is involved at the site. The one outcome of the study was that, it takes an interdisciplinary team. It takes a lot of communication, and I think the pharmacist is one of the key players here. And the other thing I want to note about this study is, and maybe where the pharmacist is playing a key role around the various clinics, is the access and acquisition of the drug wasn't really analyzed. It wasn't assessed as a barrier here, and that's because the drug company provided the medicine to these clinics, and that the study drug wasn't approved at the time that this study started. And I think that's why they had to provide the drug as a part of the study. But man, that is one of the biggest barriers and challenges to getting this implemented properly. And so while this is as real world as we can get, that piece of the real world and acquiring the drug is missing big time. And I think the pharmacists across the country are struggling. What do you think about that?
I would agree. I mean, I think you and I have both had anecdotal conversations with many of our pharmacist colleagues who are front and center at some of the processes I think remain hidden around getting a medication like this to work within a health system, like P&T meetings, or really trying to understand who is going to do benefits investigation for the medications. Even things like trying to reconcile, is it okay to white bag the medication in a clinic? Is it not okay? What impact does that have on the clinic finances if it's going to be a buy and bill situation? Are we allowed to buy and bill with the patient's insurance? There's so many nuances to something that seems as simple as just getting the drug. We've had conversations about how much an extra refrigerator is going to cost for our clinic, or who's going to walk over and how fast can they walk over to the pharmacy so that the drug doesn't expire within the time frame. So I could not agree with you more that pharmacists are going to be so central to something that seems very simple but is actually quite complicated with regards to administering, storing, acquiring the drug. That's a huge piece that I think still needs to be ironed out.
Right. And I would encourage, the pharmacists out there who are implementing, who are struggling or having lots of success, do some research, publish your approaches, present them, get them out there so that they can really help the rest of us. I think that there's not enough evidence right now looking at the role of the pharmacist, at least in the realm of HIV long-acting injectable medicines. Maybe there are some models out there for other long-acting medicines that we can learn from, but I would definitely encourage our group, our pharmacists, to get out there and evaluate our role and establish our role in a really positive way with these medicines.
Agreed. I think the learnings we have from that are also going to play into cabotegravir yet again, because we're not only looking at cabotegravir as treatment. There was data presented at IAS around cabotegravir for pre-exposure prophylaxis.
There sure was, and it's a hugely important study, the HPTN 084 study, large study, multi-center, randomized, double-blind, mostly taking place in sub-Saharan Africa. Over 3,000 individuals in this study. These were sexually active cisgender women, 18 to 45 years old, at high risk of HIV. We did have some presentation of this data at a prior conference, but we don't have the publication yet, so it's good to kind of refresh a little bit on this study. If you remember, people were randomized to either cabotegravir or placebo plus Truvada. So they're the placebo-controlled portion. So you got cabotegravir orally every day for about 5 weeks plus a placebo tablet. Then a placebo tablet in the other group plus tenofovir disoproxil and emtricitabine tablet. And at 5 weeks, people moved over to either, again, staying on the placebo, but having an injectable placebo at that point with their tenofovir emtricitabine, or now getting injectable cabotegravir, long-acting intramuscular, every 8 weeks and a placebo tablet every day. So hopefully I explained that well enough, but again, a placebo-controlled trial here. When we got to about the early portion of this study, the first opportunity for the Data Safety Monitoring Board to review the data, that was back in November of last year, they decided that this study should be stopped at that time. There were 40 infections at that point, 4 in the cabotegravir arm, 36 in the tenofovir emtricitabine arm. That was an 89% difference in risk there, lower risk with the cabotegravir, and they demonstrated superiority, which at that point was extremely impressive to me. I thought, that tenofovir-containing regimens, they're not perfect in terms of prep because of that daily, having to take the medicine daily, but they are very, very effective. And that's been shown over a number of years. So to demonstrate superiority to me was an extremely important finding. Very impressive to me. I don't know if you felt the same way at the time, specifically with the having to stop the study at that point.
It's always impressive when the DSMB says the outcome is so clear we need to stop this study.
Right.
I think the other thing that really struck me about this study is that as a pharmacist who serves many cisgender as well as transgendered women in my program, this feels like a landmark because some of the innovations in PrEP haven't been for cisgender women. So, at the approval of tenofovir alafenamide with emtricitabine, the exclusion with cisgender women, or, as the studies around 211 and that type of dosing come out, that is also not studied in cisgender women. So, here's an innovation that is superior and found to be effective in cisgender women. So this one feels like a win.
Absolutely. I mean, I can't agree with you more there. It's been disappointing, really, for the other types of interventions that have recently been evaluated, including the tenofovir alafenamide approval for PrEP, to not have included any cisgender women in their studies. At this particular conference now with the HBTN 084, one thing they wanted to do was go back and look at all those infections that happened, those 40 infections, and to really kind of dig in to see, what was it, what happened. And just looking at those 4 infections in the cabotegravir arm, they found that one of them actually was already present at baseline. So that wasn't an incident infection. Someone had already been HIV infected, had HIV infection at baseline in the study. So taking that infection off the list, going from 4 down to 3, puts them now at a 92% lower risk in comparison to tenofovir. Two others out of that 4 had no recent or absolutely no cabotegravir exposure. And the other one person had several delays over the course of their several delays in their injections over the course of the study. So overall, it seemed like if you were on the medicine, stayed on the medicine, didn't have HIV at baseline, you did quite well in terms of preventing HIV. The 36 infections for the tenofovir group, all of those were incident infections. None of those occurred at baseline. And the majority, 35 out of 36, had evidence of poor adherence, which we kind of know about the daily tenofovir. Only one of those developed resistance, the M184V. No one of the 4 in the cabotegravir arm developed resistance upon their HIV infection. So really compelling results. definitely going to influence all PrEP guidelines moving forward, and noteworthy, absolutely, in terms of including cisgender women, and well over 3,000 included in this study.
It's going to be a boon, I think, for adherence because, as you just stated, the challenge of getting PrEP to be efficacious is making sure you take enough of it to actually be effective. So having the long-acting injectables, I think, will be really helpful to allow patients to not have to think about it every day.
Yeah, absolutely. And this will be interesting to see how things roll out. These results are quite similar, but there are a little bit of differences between HPTN 084, what we talked about just now, and HPTN 083, which has now been published in the New England Journal of Medicine. That was the companion study evaluating people who are men who have sex with men or transgender women. So a lot of similarities in terms of efficacy, but a few differences in terms of those incident infections. Just quickly, 4 incident infections observed on cabotegravir there, despite on-time injections and expected cabotegravir levels, and some resistance to integrase inhibitors observed in that study too, that would influence kind of the activity of our trusted dolutegravir and bictegravir regimen. So, we'll have to see how the guidelines interpret everything and put it into play, but that is a pause for concern for me.
I agree. I think more data, it is interesting some of the differences we're seeing in 083 versus 084, and I'll be looking forward to more information as we try to figure out why.
Absolutely. And so, thinking about PrEP, thinking about long-acting agents, thinking about treatment as well, we should talk about some of the novel agents that are coming out or being investigated, and some of that data was available here at the IAS meeting.
Yeah, it's one of my favorite things, actually, to come to one of the annual meetings and hear about the progression of totally novel drugs. And one of those that was discussed at IAS was lenacapavir. So I think, as we know, lenacapavir is a novel mechanism capsid inhibitor that has a bunch of potential actions, with against HIV transport into the nucleus, perhaps has some impact on viral assembly, viral release, capsid assembly. So something really new and exciting, I think, from a mechanism of action standpoint for us. And if we thought once monthly injections were good, try on twice yearly subcutaneous injections. So, potentially something a pharmacist can teach a patient to do, and they can do at home, which I think is a really exciting innovation for HIV treatment. The 2 studies that were discussed at IAS were the Calibrate and Capella studies, and these are both studies of lenacapavir. One was in treatment-naive patients, and the other one was in heavily treatment-experienced patients. So the design for the Calibrate study, as you remember, it was sort of complicated because it had 4 different groups that they were following. And one of the groups was lenacapavir requires an oral lead-in. At least that's how they're studying it right now. So in one group, patients would do the oral lead-in, then they would get lenacapavir sub-Q every 6 months in combination with oral emtricitabine with tenofovir alafenamide for 28 weeks, and then eventually they were stripped down to just 2 drugs, which was the lenacapavir and the oral tenofovir alafenamide. They did another arm that was really similar to that, except the stripped down part of the regimen after 28 weeks was lenacapavir and oral bictegravir by itself. They did an all-oral arm, which was daily oral lenacapavir with emtricitabine and TAF. And then the last arm was sort of standard of care regimen with bictegravir, emtricitabine, and tenofovir. So lots of arms going on in this particular study. This is looking at in this particular phase 2 induction maintenance study, they kind of condensed all of the lenacapavir arms and took a peek to see what was going on now. And the results look pretty good. So at this time point, it was 94% of patients had an undetectable viral load under 50 copies per ml. Those in the bictegravir TAF arm were doing great also, so they had 100% undetectable viral load in that arm at the time point. Of the couple patients that did have a detectable viral load in the lenacapavir arm, there were treatment-emergent mutations in capsid and also reverse transcriptase. So I think it's something we're going to have to keep our eye on. It, too, is not humongous. It's still, very high rates of efficacy in both of the arms. But as we follow along, I think we'll be wanting to pay attention to treatment-emergent resistance.
Yeah, definitely agree with that statement there. You're right. It's not a very large number, but our threshold for resistance and the number of people who develop resistance has gone down dramatically with, like speaking about the TANGO and SALSA studies earlier, with 0 patients getting treatment-emergent resistance. So, it's definitely, I agree, something to keep an eye on, not to get alarmed about right now, but we'll be watching. Yeah.
Watching. Side effects in the study seemed to be mostly GI related. So there was some nausea, some diarrhea, and interestingly, it didn't seem to be that much different in the sub-Q. You'd figure if you bypass things using a sub-Q injection, it would be a lot better in the sub-Q, but maybe not so much so. So it might not be the route, it might be the drug itself. So there was actually more nausea, slightly more nausea in the sub-Q arm compared to the oral arm, and diarrhea was about the same in both arms. There were some injection site reactions. Again, I think it's early in the study, so we'll understand better what those injection site reactions are later on. I guess maybe also very briefly, the partner study that was Capella, which is a phase 2-3, and these are super treatment experienced patients, looking at them at 26 weeks. Most of these folks, they were very treatment experienced. 99% of them had some kind of resistance to nucleoside reverse transcriptase inhibitors. 97% had resistance to non-nucleosides. So these are very, very treatment experienced persons. They were on average 23 to 27 years out from their HIV diagnosis date, had been on 9 antiretrovirals prior to. So again, it's impressive how experienced this cohort was. And this is an interesting study in that they had a randomized portion of the study and then a non-randomized portion of the study. So the randomized folks, they got 14 days of oral lenacapavir, and then they switched over to, with optimized background, and they switched over to maintenance therapy with the sub-Q injections. Whereas the non-randomized folks, or placebo, and the non-randomized folks, they just went straight in to oral lenacapavir plus optimized background for 14 days, and then sub-Q lenacapavir plus their regimen. Other things to note from this study was the median age was about 50, 25 to 30%, depending on which arm you looked at, were female, and depending again on which arm, a fair proportion of them, 45 to 67%, identified as Black or Hispanic as well. So a fairly diverse cohort by HIV studies. And I think things to think about that were helpful from the study, again, this is a cohort of persons that probably does not have a lot of treatment options left. And they still saw increase in CD4 cells. The mean change was 81 additional T cells gained. 81% of the cohort, the randomized cohort, became undetectable, less than 50 copies. And the resistance testing in people 4 people did have emergent resistance, and 3 of them managed to resuppress with shuffling around some, or not even shuffling around some of the other agents in the background. So I think my takeaway from this study is that lenacapavir is going to be a helpful agent to have, particularly for our persons who may not have a lot of other treatment options left. So I'm looking forward to adding this to our armamentarium when it's ready. Yeah,
agree. It seems like a versatile drug in a way. At least that's the way that they're studying it, with all those treatment arms and the Calibrate study, and now for these heavily treatment experienced patients. And with those patients in particular, it's really hard to design a somewhat simple regimen. It's usually quite complicated. And if this is available as an option for these patients, I think it will help to simplify, at least create another option for people that they don't have to be on a tablet every day, or 2, 3, 4, 5, however many tablets daily, or the other agents in this category, the ibalizumab, fostemsavir. There's definitely attention being paid to these patients, which I think is great. Trying to get them agents that will have novel mechanisms, will work well, and maybe simplify things. So I think it's definitely a bonus.
I agree. We're really in an era where I think we are really emerging into an era where you can probably get someone suppressed, irrespective of how long they've been on therapy, how many agents they've been exposed to. We have a number of agents now, and more like this coming out on the horizon, which will allow us to really aim for that goal of viral suppression.
Agree. Yeah. And speaking of kind of new and different medicines, novel mechanisms in a way, we have another agent in islatravir that I think, we're all kind of looking forward to. It is novel in that it's a nucleoside reverse transcriptase translocation inhibitor, so kind of a first-in-class agent in that class. And at the IAS meeting, there were 2 studies presented trying to, figure out this medicine a little bit, at least introduce it more to people. And these 2 studies, Protocol 11 and Protocol 16, not as interesting as TANGO and SALSA and Calibrate and Capella, but the studies were important nonetheless. So Protocol 11 was a treatment study, and this was looking at using islatravir in combination with doravirine and lamivudine as a daily regimen. Okay, now islatravir we know can be potentially used as a long-acting agent as well, but it is being investigated as a daily option as well. And this was a dose-ranging study, a couple of different doses, 0.25, 0.75, and 2.25 milligrams, all in combination with doravirine, lamivudine, and then in comparison to doravirine, lamivudine, and tenofovir disoproxil, that regimen that's already kind of approved and established. And about 30 patients in each treatment arm, and really what they were looking at was safety. And in the end, fairly safe medicine, not a lot to talk about in terms of adverse events, some headache, some diarrhea, probably the most common, but typically anticipated types of adverse events. Not a lot of drug-related adverse events or discontinuations. Not a lot of relevant changes in laboratory values. Pretty boring in that regard, but in a good way. So that's kind of Protocol 11. And let me just mention Protocol 16 as well. It was looking at PrEP in terms of using islatravir, and I think it's an exciting potential option for PrEP down the line. Right now, this was a phase 2 study, I think, and it was about 250 patients. Islatravir 60 milligrams or 120 milligrams compared to placebo, all given as monthly tablets. Again, kind of a safety analysis and some pharmacokinetics as well. Safety, again, headache, diarrhea, nausea, all kind of mild grade 1 stuff. No real discernible differences between the doses or the placebo. Really, placebo actually had a few more adverse events in comparison to the active treatment arms. Interestingly, the PK, or the pharmacokinetic analysis, what they did was look at intracellular concentrations of the active form of islatravir over the course of several weeks after the last dose was administered. And I think what was interesting was that even at 8 weeks after the last dose, didn't matter which arm you were in, 60 or 120 milligrams, the concentration still remained well above the pre-specified target for HIV prevention. So I think that bodes well for this agent in terms of PrEP and thinking about it as having maybe a little bit of forgiveness there if a dose is delayed or missed. But, very long-acting agent stays active a long period of time, well after the last dose was administered.
That seems to be a theme. We're really looking at medicines. I mean, I can sort of think back to the day where we had HIV medicines that just did not last very long. When you think about AZT and its half-life, now we're looking at these half-lives that are incredible, which I think, as you mentioned, is really important for creating those forgiving regimens, for creating convenience for patients, thinking about novel delivery systems like subcutaneous and implants and injections, et cetera. It's early, I know, in the development of several of these medications that we've talked about, but it's exciting to see what's coming down the pipeline.
Absolutely. I think as providers, pharmacists, patients, we should all kind of be excited at the fact that there's new agents still being developed for HIV infection. They're novel. They're different. They're in terms of, like you said, delivery systems and half-lives, and they're creating more options to manage this infection or prevent it, really. And that's exciting to me.
I agree. I think as pharmacists, it's really important for us to stay abreast, and it moves fast. I mean, I think that during the ebb and flow of creation of medicines, at some point we thought we were doing great when we were at integrase inhibitors, and pharmacists were kind of like, okay, these are the last medicines I need to learn about. But there's more, and I think that's a really exciting thing, a really important thing. As these new agents emerge, pharmacists are going to be asked questions about these. Pharmacists are going to be central to access of all of these new medications as we figure out how to move them through the health system to patients, to make it affordable, accessible, to monitor for side effects. Again, I think with new therapies, I think it just cements the need for pharmacists to stay on top of these things and to take an active role in monitoring, counseling, and sometimes furnishing or providing for the patients.
Agree. I absolutely agree with you, and hopefully we learn some lessons in terms of the cabotegravir and rilpivirine injections that we're using, and we can apply those to our new agents moving forward.
Thank you. It was really wonderful to spend time with you this afternoon, Dr. Schafer. Hope to speak with you again soon.
Thank you very much.
Thank you very much to Dr. Cocohoba and Dr. Schafer, and thanks to our listeners for joining in. As a reminder, if you would like to hear short presentations on additional topics related to the care of patients with HIV, I invite you to visit the Clinical Care Options website by clicking on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.